Well, thank you so much, Abdul. I think this session has really teed us up very well for our closing session with Dr. Derek Griffith, who many of you know already. He is a distinguished scholar in psychology and public health with a specialty in men's health and health disparities. And until very recently, he was a professor of medicine, health, and society at Vanderbilt. And he recently relocated to Washington, D.C. area as the founding director of the Racial Justice Institute at Georgetown University, which is a university-wide initiative. Dr. Griffith also serves as a professor of health systems administration in the School of Nursing and Health Studies, which is part of the Georgetown University Medical Center. He's known, mentored, and worked with several of our previous speakers over the years. We had some very nice reunions in the run-up to this session. He knows our field very well. And also, on a personal note, as someone who grew up here and has lived and worked in DC for most of my career, I'm especially glad to welcome him and his leadership, insights, and perspectives about where the field of health equity research needs to go. So before Dr. Griffith takes the floor, I think we have one more poll. And that poll would be about how you're feeling about your expertise in this field. So do we have the Zoom poll?
The last poll will also be over Slido. I sent the link.
Okay. Okay, thank you. Thanks, Priya. So here's our final poll. I think this will help tee up Dr. Griffith's remarks. One of the points I think we're going to hear about is learning and unlearning, how important that process is. Okay, well, thank you so much, everybody. So Dr. Griffith, over to you. Thank you so much for being here. Welcome.
Thank you. It is truly a pleasure to help try to, tie a bow around this wonderful day. It definitely has been a tremendous experience for me, having been able to be a fly on the wall, if you will, and participant throughout this whole day and been able to see the panels from the beginning. So it really has been tremendous. So thank you for doing this, and thank you for inviting me. Let me just start by saying it's, just given the last few polls and just given, the focus of the overall day, I think speaks to just, the obvious thing of how important racism is, how important just understanding a lot of the basic terms and concepts, and how to do work from an anti-racist perspective is still a very contentious, still a very complicated, still an unclear space for us to operate in. And we know that a lot of the questions that came up throughout the day about how to measure race, how to look at things like ethnicity and so forth, are really questions that are anchored in anchored in our ability to really understand how race is a proxy for how people are experiencing racism at multiple levels and how it's affecting their health and well-being over time. And so we have to sort of look at it through that way and always remember that essentially race is, how do we think about race as essentially a proxy for some of these other factors, as Tom Levis has been saying since probably the mid-90s. We know that race really came out of a history and legacy of racism. So we have to make sure that we understand it in that context. And this idea of anti-racism is really about being very conscious and thoughtful about how we address these issues, how we think about these problems that we're trying to think through, and how do we become not just better people, but better scholars. One of the big challenges in the space of this work has been that historically, when we're trying to train people on how to do things from an anti-racist perspective, we haven't really done a good job of disentangling what we want people to learn about and do differently as human beings and as individuals outside of their work, from what are we actually asking them to do in the context of their explicit job work and specifically what they do in their daily job. And so I think what has been great about today is we've helped people who do very specific things to think differently or to add to what they know about how to do their specific job, whether it's a statistician who's looking at how to measure, different factors and variables, whether it's, Dr. Barlow and bringing in things like intersectionality and the importance of qualitative research. And I would even argue from her other work, the importance of historical context and how that really needs to be brought in, not just from an individual sort of life course perspective, but really from a structural standpoint, how these things affect health and so forth over generations. It's important also to recognize that these are very contested spaces. This idea of focusing on race and racism, as Dr. Tucker Seeley was sort of alluding to, and I'm sort of taking a little liberty with what he was saying in just these last few comments, but there's a larger context of how do we have professional careers? How do you have successful careers in doing work that not everybody sees as necessarily valuable, is much more difficult to get funded, and much more difficult in some ways to build a professional career around than, say, studying fruits and vegetables, things that are much more traditionally within the space of, diseases, behaviors, and so forth. And so when you're committed to doing that work, it does become more challenging than simply doing things that people have accepted as, the natural sort of fare and focus of public health and health services. And yet this is something that we have to figure out how to grapple with and how to support people and retain them in those roles and responsibilities that they have in the field, both in health services as well in broadly public health. And so it's important to recognize also that when we talk about anti-racism, people can have different definitions of what that means. And it's not a question of whether or not people are well-meaning or intent or committed and so forth, but we're going to have different definitions of what that means and what we're trying to achieve. And we need to make space for that, but we also need to make sure that we're very clear about how we're defining these issues and terms. I think one of the key takeaways from Dr. Tucker Seeley, again, I'll extend sort of something he said from the beginning, and the first paper too, was about the need to really define explicitly the terms that you're using and to be really clear about how that affects the way you're operationalizing these variables. With some of the questions that just came up around reducing bias and research questions, it really does come from making sure that you clearly understand what you're doing, why you're doing it, and what implications the choices that you're making actually have. Something as simple and ubiquitous as including race as a variable or reporting data by race has to be more effectively interrogated in how we understand what that actually means and what the differences are that you're actually seeing. It's important, we don't do this enough, that we don't actually spend enough time thinking about a priori, what does it mean if we see a racial difference? Does it actually have some meaning? And as it's kind of a flip on some of the questions and comments that were in the chat earlier, it's not a question of once we have a finding, how do we explain it? We need to know how do we explain it before we actually find it, and which differences actually matter and which differences really don't. And these things have, historical context and significance. Without getting into too long of a story, the National Negro Health Movement, for those of you who are, it's work that Sandra Quinn and Stephen Thomas studied. They did a couple of papers about the history and context of it, and I've done some stuff to sort of talk about its relevance as well. But the importance of that is it was an initiative that ran in the first half, essentially, of the 20th century, and it was arguably the most effective intervention, community-based intervention that has been done that actually improved, and we actually saw a decline in the disparities between Blacks and whites in terms of health outcomes. It was so effective that they actually closed the office that actually ran the study and decided, and the language actually very explicitly says in the explanation for why they closed the office, that the difference was no longer significant enough that it was required, that we needed to have such a separate office to focus on the needs of that particular population. And so there was no need for having an Office of Negro Health Work, which I think is what it was called. There was a need to just fold the needs of African Americans into the larger community. So it's important to sort of understand that these things are not just, semantics and so forth, that it really does have important implications for how we do what we do. when we think about issues of race and racism more broadly, it's important also, there was a great point and presentation that included a framework thinking about power. I'm going to offer a slightly different one that thinks about power sort of at three levels. It's a variation of what Stephen Lukes proposed in the mid-70s, but it's kind of bringing that, it's basically that framework, which, yes, we mostly think about power in terms of who makes decisions and so forth, and who has the power to make a choice and a decision and those factors. But the other questions that you have to think about before you can make a decision, it has to get on the agenda for there to actually be, or prioritized enough to actually be discussed to be actually make a decision about. And if you're setting the agenda, and this is where the importance of groups like Academy Health come in, is that they're putting these kind of key issues on the agenda to actually make decisions to help people inform the decisions and the choices they're making about how they're going to do the professional work they're doing. And then thinking about broadly, how do we navigate the larger ideology, worldview, meaning that we have in the work that we do, and how central, as many of the leadership have said from Academy Health, how do we think about the role that health equity plays in health services research? Is it something that's sort of marginal to it, or is it now going to be something that is really central to the work and what it actually means, what it's trying to achieve? And so if you think about that and the importance of that and the significance of that, that speaks to the foundational issues that we're talking about when it comes to issues of race and racism. That racism is this broader sort of umbrella that really does shape the meaning, the purpose, and so forth, as well as things like, structural racism. We can get into the semantics of those issues, but how it gets on the agenda for, say, NIH is very different. And now it's taken a while to get to that point versus foundations, as you all talked about in the last session, that have had this on their agenda much more explicitly for a longer period of time. And we know there are lots of challenges with doing this work and so forth, but how we facilitate the unlearning at an individual level, how do we facilitate coming up with, so there was a lot in looking at some of the strategies that we discussed or that were discussed and actually throughout the day. And how do we facilitate making sure that we're more critical, thoughtful, and intentional about the decisions that we're making to include certain variables, to ask certain questions? How do we refine the questions? Even the conversation that was discussed both by Dr. Barlow as well as in the chat quite extensively about within group versus comparative sort of studies. And one of the things to think about is, again, it depends on the goals of the work that you're doing. Comparative studies are useful, but they're only useful to define whether or not there's a problem between two groups. If you want to actually improve the health of a particular group, comparing them to another group doesn't really help you. You need to know what are the strengths, what are the anchors, what are the foundations, what are the root things that you can build from within a particular population to then be able to, you can't look at them as just a group that's bereft of any kind of strength, assets, or abilities. You have to look at for groups and build them from the strengths that they have. And this is sort of one of the foundations that Dr. Arian Bua had with the PEN 3 model, the program planning model, that looks at things like basically rooted in culture and other historical factors. But it's really important to recognize that there's value in both, and people have been doing both for a very long time. The Program for Research on Black Americans has done a lot of survey research since the 80s on just looking at Black Americans, and whether it was the National Survey of Black Americans that was done in about 1980, whether it was the National Survey of American Life, that's the first the National Survey of Black Americans was the first nationally representative sample of Black Americans. And even though it was 30, 40 now years ago, the work faces the same challenges of that it was difficult for them 40 years ago to get it published, because people it wasn't that the work wasn't rigorous and it wasn't good. It was nobody understood what the findings meant. And it was important to understand, well, what does it mean to have this particular pattern or this outcome for, in this case, Black Americans, but you can think about other racial and ethnic groups as well. How do we understand those issues within that particular group? They did some comparative work, but the National CPS, National Comorbidity Psychiatric the epidemiologic survey, they did it around 2001 to 2003, had population-specific groups, but then it also had an overall collaborative psychiatric epidemiologic survey. That's what I was trying to get to. And then they had population-specific ones, but the point is that there was a recognition that we needed both, comparative things to figure out who's doing worse and who's doing better. But then once you figured that out, it's important to figure out how you're going to mobilize the resources through a CBPR approach, through, potentially something that's maybe arguably, hate to be, a little contentious, but less rigorous or less invested as community engagement. I think community engagement is kind of it doesn't sort of take on the same level of collaboration and decision-making sharing that was discussed when we were talking about CBPR earlier, that it's reducing some of those choices around decision-making and leaving a lot of the power in terms of decision-making in the hands of the academics, versus the way that Dr. Rojas was describing it was really talking about it as more of a shared process throughout the whole, from beginning to end. And so that process and thinking about that and bringing that kind of approach back, is something that not everybody, again, agrees with, but we have to sort of think through and going forward. So the last point I'll make is that, when we think about this idea of doing anti-racist work, it is important, again, to recognize not just how it affects the outcomes that we're talking about for our particular population, but to recognize that we're affected by the same outcomes and the same structures that the people that we're studying and the populations that we're studying are. So we need to understand the contentious nature of the politics of the society that we're in at this particular moment, the era that we're in, and how those things are shaping whether or not you can discuss explicitly certain topics or not. One of the pieces in our Racism, Science, and Tools for the Public Health Professional book that we did 2019 has an interview I did with David Williams, where he was talking about, some of the very contentious nature of some of the early work that he was trying to get published on using the term racism. And it was very similar to what some of the comments were today, is that if you wanted to get the work published or even considered for funding without just getting triaged, you couldn't use the word racism. Now we've moved far enough along where you can actually at least explicitly discuss it. But depending on how you operationalize it, not everybody, you're going to potentially still get it triaged, because you have to really think about explicitly what do these factors mean and how do they relate to the outcomes, and can you actually show the mechanisms and pathways that connect that to the outcomes of interest. So we have to work from both sort of a Nutcracker effect, if you will, both how do you think about the factors that relate to structural racism and the outcomes of interest, but then also think from the outcomes of interest, how do we work backwards through the behaviors or through the mechanisms that we see as important to understand what are the most important key mechanisms that we can manipulate or that we can invest in to make the changes that we're talking about to achieve the outcomes that we're interested in. The last quick thing I'll say is we don't necessarily agree. Again, this is sort of playing on Dr. Tucker Seeley's comments from the beginning. In addition to the definition of things like disparities, inequalities, inequities, and so forth, we don't actually agree on the outcome of what equity actually means. So is equity, in Healthy People 2030 changed the way that they talk about equity to really reflect more. The goal with Healthy People 2030, at least in the explicit language that I've seen, reflects that their goal is to try to equalize the opportunities for people to be healthy. And they took their focus away from measuring the similarity in outcomes and took their attention away from some of the comments and questions about how do you know certain outcomes are differences versus how do you know certain outcomes are disparities or inequalities or something that's worth attention and addressing. And while I understand the logic behind that, the fact that we don't have explicit agreement about what it means to achieve equity, is it that everybody has the same outcome? How long do they need to have the same outcome? How far do you need to disentangle and break down some of the things that Dr. Ponce was saying, and again, using an intersectional approach from Dr. Barlow, how do you think about which groups need to be equal on whatever outcomes that you're talking about, and how long do they need to be equal? Is it just for a period of, a particular moment in time, and okay, now we've reached that, okay, we're good? Is it need to be 5 years, 10 years? How do we understand what these outcomes and things are? So in summary, I think this is a great start to the conversation, or continuation of a conversation about how do we better understand and be more precise in terms of understanding the determinants of health that we're talking about, labeling racism and how it's specific to different groups. I think that was something else that came up here. The history of racism as it relates to, say, Black women's health or Black men's health, to Native Americans' health, to Asian Pacific Islanders, and breaking those groups down. The history, the context, what racism actually means, and how those factors affect the populations, again, generationally, as well as within the life course of individuals, is something we can't assume is going to be equally, is the same for all groups. Let me just say it that way. And so how do we make sense of that is going to be particularly important, using approaches like Syndemics to really understand how these combinations of factors are going to be really important for us to think through as well. So this was a great start, or a great continuation, and I look forward to being part of, whatever happens next. So thanks.
Well, thank you so much, Dr. Griffith. And since I'd like to ask you to respond to Dr. Tucker Seeley's question about how we define equity. And I was thinking maybe you could tell us a little bit more about Syndemics, which is kind of not everybody might be familiar with.
Yeah, I mean, how we define equity is, like I said, rather contentious, and it kind of depends on who you talk to. Again, that's really more of a question than I necessarily have an answer to. I think when I've talked to people and presented on this and talked about the idea, okay, so when you say that you're trying to achieve health equity, what exactly do you mean? And I usually get more of a puzzled look. Well, of course, it's sort of self-evident what you actually mean, but then I'm like, well, no. So for the difference, again, because people are usually not looking at things like big picture, things like you were talking about earlier, infant mortality, life expectancy, and so forth, usually talking about specific health issues, and even issues that are more specific or narrowly typically within the purview of health services research. So then you're talking about differences in terms of quality of care, access to care, and those kinds of things. So is that the difference just needs to be statistically insignificant? Is it, and is it just within a particular setting? Like all of those kinds of nuances are things that we have to really start to dig into. So I think that kind of precision, again, is going to be really key to understanding that question of equity, and to bringing that level of specificity that he was talking about initially. There was a second part to this. I'm always bad with two-part questions. So that was the first part.
I'm sorry, Syndemics.
Oh, Syndemics.
Yeah.
Syndemics are basically the idea that you, it's kind of taking the idea of the population vulnerability and recognizing that structural factors are usually clustering within a particular group because of the structural challenges that they're facing. And so you would have basically, so if you think about COVID, for example, the reason that COVID was so problematic for certain groups was because they were in a physical space where they were more likely to be exposed to people who had potentially may have the virus, but then they're also more likely to have a higher concentration or prevalence of chronic diseases that meant that they were more immunocompromised. So it's put in the context of, Syndemics also brings into play the image of really thinking about the structural conditions that shape the concentration of disease in a specific population, and the concentration of chronic disease, and the concentration of the infectious disease that you're talking about. It's usually the combination of those, but it puts it in social and historical context. So that's really what Syndemics sort of reflects. And then you have a mechanism, a biological mechanism like stress, inflammatory factors or something like that, that connects those, that the structural factors are triggering, and that is exacerbated by having a chronic disease and an infectious disease happening at the same time. So in our work, we did a piece that was just in public health reports that use a Syndemics approach to talk about why Black men had the highest rates of mortality from COVID in the first half of 2020. And we use a Syndemics approach and an intersectional approach, actually combine intersectionality and Syndemics to basically try to make sure that we were clear about what does it mean to have anti-Black gendered structural racism as a driving factor that affected the health and well-being of Black men, so that their life expectancy dropped 3 years when everybody else dropped less than 2.5 within just a 6-month period. So that's the kind of thing that I think we need more precision on in terms of a theoretical approach, methodological approach, and really refining and taking those things on. As I was on a panel really quickly yesterday, one of the great quotes that I got from Dr. Gilbert G was, "We're not going to health belief model our way out of structural racism." And so we really do need more precise, more clear theories and context and ways to model and operationalize what we're talking about and how we're going to address those kinds of issues.
Thank you so much. There's so much promise, I think, in that approach. I think of Syndemics as kind of intersectionality meets epi, but that's probably another conversation. So thank you so much, Dr. Griffith. I really appreciate your being able to weave all of these threads together. Thank you for joining us today. And we have about 5 minutes. What I'd like to do is wrap up, just quickly synthesize what Dr. Griffith synthesized, if I could do that. That this field and some of the themes from today, this is a contentious, complicated issue. It's hard to get funded and published, but we want to be better people and better scholars. So we're going to look at our definitions. We're going to try to find a way to work with top-down and bottom-up methods, involve communities. We have a combination of big picture and very detailed and contextual frameworks that go all the way down to granularity, the imputation and missing data. So I think we've given lots of suggestions for future research methods. We've talked about the realities of funding. We've also talked about looking in the mirror to see biases, what differences matter and which don't. And also how to center health equity in health services research and define what equity means, I think is where we left the conversation. So it's been just an amazing day. I want to thank all of our presenters, all of our moderators, all of you who have participated today. Thank the team that worked behind the scenes to put this together, Priya, Amy, Troy, Kristen, Pam, and of course, Lisa. I'm sorry, Dawn. We want to make sure that we thank PCORI once again and the Robert Wood Johnson Foundation Paradigm Project for their support. And I also wanted to let you know that an evaluation form is going to pop up as soon as we close out today. So please spend a few minutes online and a few more minutes online and give us your feedback about today and what you'd like to see happen next. As we mentioned, we do have a report coming out soon, and we're really delighted that so many of you were able to participate again. So again today. So thank you so much. Enjoy the rest of your day. Be well and stay safe. Thank you. Bye.